have to stop the total shutdown right away. And the answer is just do what the Italians, just send everyone back to work, send everyone back to school.
If you take 25 micrograms of vitamin D3 in gel tablet form once a day, your risk of A, getting, and B, suffering from COVID-19 is very greatly reduced.
There is no known prevention, there is no known treatment, and there is certainly no known cure.
Sweden let the virus circulate and created herd immunity. By doing so, they will not have to endure a repeat operation of a lockdown.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. Today we'll be reflecting on Canada's response to COVID-19, as well as what our exit strategy could look like. As provinces and territories begin to ease restrictions, will this unleash a second wave of COVID infections? And how do you mitigate risk to those most vulnerable? At the panel, we'll seek to answer these questions and more. But before we dive in, let's tee up the topic.
As countries around the world begin to lift COVID-19 restrictions, here's what we know. The number of known coronavirus cases in Canada has exceeded 60,000, and around the world has topped 3.5 million. Provinces and territories have listed 26,000 cases as recovered. Meanwhile, over 4,000 have lost their lives. While the rate of increase in cases and deaths has started to slow, this is not true for congregate settings like long-term care. Canada has joined the global community in helping to raise $11 billion toward the ultimate COVID weapon, a vaccine. However, experts estimate we're still 12 to 18 months away. In the meantime, governments struggle to reopen economies while keeping COVID at bay.
Lord Black, I wanted to start with you. You've written extensively about Canada's response to COVID-19, so give us your thoughts. Where are we today and how have we done? How has Canada responded to this crisis?
Well, I think our results have been quite good, and I'm not exactly sure why we have done better than all other large countries in the Northern Hemisphere except Germany and Japan. But I think somebody deserves credit for this, and we can pat ourselves a little bit on the back for that. On the other hand, I think we are very slow developing, or at least publicly developing, our exit strategy, because things cannot go on like this. I have to say this, that approximately 80% of the fatalities are in the 20% of the population that's above 65. And in Canada, that means that for those above 65, the fatality rate is about 1 for every 2,200 people. But for the other 80%, the fatality rate is about 1 for every 18,500 people. Now, every one of these fatalities is a sadness. I'm not making light of it. I'm not monetizing it. I'm not getting into the business of costing life. But we cannot shut down so much of the economy as we have and brought so much anxiety and financial impoverishment to so many people for that small a statistical sample. So the last part of your question is the key. How do we segregate in the sense of protecting the vulnerable people? It's shocking what's going on in these old age homes, not only in this country, but elsewhere. There must be ways of doing it. I thought it was a dramatic gesture, probably not effective medically, but a dramatic gesture for the Prime Minister to send the armed forces into some of these places to help the clerical people in them. But we've just got to screen visits to those places and make sure that they're kept as hermetically sealed as possible without making the lives of the people who live there impossible. But we have to stop the total shutdown right away. And the answer is just do what the Italians, just send everyone back to work, send everyone back to school. School children don't suffer these things. They do convey them to their elders, but we're just going to have to live with the danger of 1 in 18,500 people under 65 dying from it. I mean, it's a terrible thing, except it's not an unusual thing. You know, all lives end somehow.
You've raised a number of valid points, and Dr. Rao, I see you nodding your head there. And, do you think that our leaders in some ways underestimated the severity of the pandemic, at least in vulnerable settings like long-term care homes? I mean, how did we fail to predict that outbreak?
Well, we didn't have a lot of experience in other countries with long-term care outbreaks until they were actually happening here. If you remember, BC had the first one at the Lynn Valley Nursing Home in Vancouver, and that was contemporaneous with what was happening in Washington State, where they realized there was local transmission. So all of this was happening at once. Europe and Italy were also starting to experience big outbreaks. I think what happened in Canada is a combination of luck and good work. They say you have to be lucky to be good, you have to be good to be lucky. We had the fortune of not seeing local transmission of this virus as soon as Northern Italy did. Northern Italy was caught with its pants down. There was 1 week between their 100th case and their 100th death. So it means they had a lot of local transmission well before they realized it, and then it was already circulating in the community. And by the time you see deaths, there's a delay of about 3 weeks from when you're infected to actually dying. That window was too tight, so they weren't testing people enough to find it, and they weren't guarding the vulnerable people. We had the advantage of time on our side.
Dr. Gorfinkel, I'd like to get your take on Canada's response up until this point, and I'll preface it with a clip of you from early on March 5th, when asked a question about the severity of this then. It was just an epidemic. Let's roll that clip.
The chances of this influenza becoming the next Armageddon, for all intents and purposes, is probably zero. It's not zero. Okay, let's be theoretically honest. It's probably 0.00001, but it's out there. Okay, we got to consider that. But as far as stopping traveling and stopping what you're doing, I refuse to feed into this craziness.
Now, in fairness to you, it wasn't classified as a pandemic yet, and we had nowhere near the number of cases. I mean, it was shortly after that I think it skyrocketed. But where are you today? Do you agree with the measures that have been taken?
I do agree with the measures that have been taken. Time has spoken. And at this point, with over 60,000 cases diagnosed and over 4,000 deaths, and a rate of rise in the number of cases that is so concerning, I don't think there's any place for what I had said before. But that's the scientific method, to understand, to see what science is, what the data is showing, and then being able to adjust to what it's now showing. And I think what it's showing is very, very concerning. I have remaining concerns, which is we still don't have enough testing going on. We still don't understand how many people are asymptomatic. And that's one of my huge concerns about just turning the economy back on and running back to the way things had been. I think that that's not the best idea at this point. I think we need to take it step by step to see the effects of those minor changes, to understand if our ICUs and our emergency rooms are going to get hosed by this.
Dr. Zak, very quickly, I think many of our leaders probably felt the same way as Dr. Gorfinkel in the early days. And so I go back to my original question. Do you think that we underestimated the severity of this pandemic from the very beginnings? And could that have made a difference?
So could it have been done better? I think you can always look back and say things could have been done better. Probably especially here, and probably especially, as Lord Black said, in the old age homes, which have been a complete disaster, a human rights disaster. But I do think a lot of work has been done and continues to be done, and I think that we are making a difference with the measures we're doing, but we can't forget the other side, which is the amount of potential damage we're doing by keeping all the kids at home, and by keeping, it troubles me that so many older people who are in institutions are essentially prisoners in their rooms for 2 months now. They can't leave their rooms. It's just awful. So there has to be a balance, the amount of damage that's being done by this awful virus that we know is killing people versus the amount of damage that's being done to society from this lockdown.
Well, I want to pick up on that, but first we need to take a short break, so don't go away.
It troubles me that so many older people who are in institutions are essentially prisoners in their rooms.
Welcome back. Since the pandemic's beginnings, anti-lockdown protests have ensued. Ontario Premier Doug Ford even labeled one group a bunch of yahoos and dismissed calls to lift stay-at-home orders. In a recent survey, a majority of Canadians indicated support for the shutdown, but around the world, a growing chorus of academics, public health officials, and politicians are making the case that extreme lockdowns aren't necessary. Now, Lord Moncton, I want to get to you in one moment, but just before the break, Dr. Zach, you mentioned seniors in nursing homes being prisoners. Isn't that the best way to keep them safe, isolating them?
Keeping them in their rooms all the time without the ability to go out, without the ability to see people. I understand there have to be some extreme measures, but I do think there's room for some humanitarian way to allow them to leave, to get outside, because you have to remember, especially if a lot of people who are institutionalized already have borderline function, and if they are staying in a chair, staying in bed for 2 months, at the end of all this, they may not be functional at all. We're actually taking away their potential ability to function in society. So there are safe ways to keep them separated, whether we put them in gloves and gowns and masks and take them out individually, or something to get them out and at least be able to see their families, even if it's from 6 feet away. I just think it's really a form of torture. And these are our elders who have worked their whole lives so they can just see themselves cooped up in their rooms like this. It's awful.
Well, and my fear, of course, is that if we do open the world, then the best way to keep seniors safe in long-term care would be to isolate them further, because now you don't know where, someone may be coming to visit and perhaps they've been exposed to something that they maybe otherwise wouldn't have been, since for the most part we've all been in isolation back at home. But Lord Moncton, I wanted to get your thoughts from the UK. Do lockdowns work?
We left our lockdown very, very late. Now, to be fair to Her Majesty's government, one reason we were late is that the Chinese Communist Party, in conspiracy with the World Death Organization, was going around 6 weeks after China can be proven to have known that human-to-human transmission was happening. And the World Health Organization was echoing China in saying, not only is this transmission unlikely, but you shouldn't shut down travel to and from China. They were giving precisely the wrong advice all the way through until late January. And that's why so many governments were not warned in time that this infection was on its way to them. And so I do feel some sympathy with governments. Even then, Britain left it very late. As a result, we now have the second highest number of deaths in the world after the United States. In Britain, 2 weeks after the lockdown was announced by the Prime Minister, we reached a peak in the daily new cases. And 3 weeks after he announced the lockdown, we reached a peak in deaths. There's always a time lag of about a week between cases and deaths. And now it's all on the decline. So we've put the fire out, if you like. But if we now want to get people back to work, and that I think is the sense of most of the speakers here, then the way to do it is to pick up on Lord Black's very sensible point, which is that younger people, anybody under 60, is essentially not much at risk of this, probably less at risk of it than with ordinary flu. If you're over 60, then the risk to you is much, much greater than with the flu. Let the under 60s travel about, go back to work, go wherever they want, and let the older 60s, the likes of me, look after themselves. It's up to me to take my precautions, not to expose myself to this. I don't need to be told by the government to do that.
Okay, but just because you're under 60 doesn't mean that you're not vulnerable to susceptibility to COVID-19, Dr. Rao. And there are some public health officials and there are some scientists that argue that these restrictions ought to last longer, maybe 18 months to 24 months. And as many are predicting a second wave, what does this mean in the fall? We've got influenza coming. We've got a number of people that whose treatments for cancer and other elective surgeries have been delayed or suspended because, we wanted to clear our hospitals for these patients. What does that mean for our hospitals? I mean, I think there are a number of things that we need to factor in here, no?
When you're dealing with people under 60, the risk is incredibly low. Yes, there will be the occasional tragic death in someone who's otherwise healthy, and the media will exaggerate it because the media loves numerator stories, not the denominator, which is the ocean of people who didn't get a bad outcome. And in a way, what is being espoused by Lord Monkton is a Swedish strategy. They've been doing this from the get-go. That's the elephant sitting in the room in the entire discussion here. Sweden let the virus circulate and created herd immunity. By doing so, they will not have to endure a repeat operation of a lockdown, which is economically unsustainable and which causes numerous other harms, as you just mentioned, Melissa, people waiting for surgeries, other forms of care being ignored, and also the issue of business continuity, that you can't keep turning these things on and off. You're toying with people's livelihoods, their dignity, their ability to make a living, and health and wealth are actually linked. If you don't have wealth, you have poorer health. I think we always forget that. I think it's very easy to look at other jurisdictions who got it right, but what is starting to become evident is that if you don't have a population that has seen the virus will come and find them later.
Dr. Gorfinkel, very quickly before I throw to break, do you agree with that? Herd immunity is the way to go.
At this point, there's so many unknowns about this virus, it's very hard to be confident. I am fearful of overly reductionist solutions for this. And I would favor the dance backward, which is basically a more gradual opening and understanding what one small modification will do, and then seeing its effects on the number of new cases being diagnosed, seeing its effects on the number of deaths. So when we go back, we can never go back to the way we were, because we know that will result in a lot of deaths and hospitalizations. It will overwhelm our already very thin hospital facilities. The idea is to keep the numbers down. The fact that there will be a phase 2 and a phase 3 is not even in question. There will be. The question is, can we keep those numbers down? And I'm afraid that if we just open up everything, because we know 80% of cases plus are actually community acquired. They don't have a history of travel attached to them. So we have to do it with caution.
When we come back, how to safely reopen the world. That's next.
And we know there are regional differences. You can't treat Ontario as one entire region with the same approach.
Welcome back. Provinces across the country have begun easing COVID-19 restrictions. As of May 4th, Manitobans can go to the hair salon, massage therapist, and restaurant patio, albeit at half capacity. Manitoba, Saskatchewan, and Alberta are also letting non-essential medical activities such as dentistry and physiotherapy resume. Ontario is allowing a number of mostly seasonal businesses, from garden centers to golf courses, to reopen, while Quebec is easing the lockdown on schools and retail stores outside the Montreal area. Now, Dr. Zach, Quebec's talked a lot about reopening its economy, but over the weekend, we saw a spike in positive cases as well as a number of deaths. Is this the right time to be easing restrictions?
Well, at some point we have to do it, right? People have to get back to normal life. Having said that, the Premier Legault, certainly recognizes that Montreal is the hotbed, and so he's delaying things specifically for schools, and I think for businesses also, he's delaying things further for the Montreal area. But we do have to go in steps. So we do have to open things up, and then we have to maintain the level of infections below that threshold where we no longer have the resources to treat them. We don't have the oxygen, we don't have the ventilators and whatnot, but we have to start at some point. And so I've heard it called I think they called it the hammer and dance. Essentially, basically, you open things up to a certain extent, and then you give it a couple of weeks, and you see if you need to pull back, fine. If not, if you're operating well, then you can try and open up further after that.
Lord,
it has to be somewhat experimental.
Lord Black, you've been clear. Now is the time to reopen, and there's no excuse not to. So what does that strategy look like? Is it gradual, or is it quick?
Well, I think you open up everything. I mean, when you get right down to it, I understand that the medical profession are not economists, and economists are not always accurate in their own field anyway, but the basic arithmetic is quite clear. As I said, in this country, we're suffering one fatality for every 18,500 people beneath the age of 60. And you cannot inflict a state of unemployment of 25% for that small a statistical sampling. And that's not, as I repeat, a monetization of life. I think the 900-pound gorilla in this room is the United States election. The hysteria of the Western media was fanned by the anti-Trump media, having failed to bring him down with that nonsense about colluding with the Russians or with that phony impeachment. This came as godsend to them, and they've tried to hang it around the president's neck, but he's outmaneuvered them and become the leader of the reopen the economy.
Dr. Rao, don't you think physical distancing measures should stay in place for some time, even if we do ease the lockdown or lift some of those restrictions? And, I would ask that because, there are a number of professions, say people that work at banks, that can continue to shield themselves behind barriers or even at grocery stores. But what about people working on oil fields or in construction? I mean, what does that mean for physical distancing? Is there a need for that to continue, or do we just lift it all together?
Let's look at the outdoor versus the indoor environment. If one is outdoors, you have air circulation. We know that the biggest outbreaks have occurred in indoor environments. There's the famous Ischgl, Austria ski area outbreak where they were indoors, dancing, partying, singing, kissing. There's a carnival in a town in Germany where there was a massive outbreak amongst young adults. Similar indoor environment story, and also in Bergamo in Italy, the epicenter of northern Italy, another similar precipitating event, which was probably a big driver for infections and huge numbers of infections. So indoors versus outdoors are different. Telling people they can do a garden center pickup, but only by curbside and not actually visit an outdoor garden center in Ontario is preposterous. Chaining down cherry blossoms and giving people video access when they can walk outdoors, be they socially or physically distanced or not, is an AK-47 sledgehammer approach to a problem. And I really am sad to see that in Ontario, we don't even have a differing approach between one area of the province or not. Timmins, Ontario gets the same treatment as Barry's Bay, as Ottawa, as Toronto, as Kingston. And we know there are regional differences. So you can't treat Ontario as one entire region with the same approach. That's another really sad thing I see. I think when it comes to kids missing school, I do want to underscore a story that was a leader in The Economist this week, which is that children should be back at school. The social harms of children, especially from lower socioeconomic groups, missing school are massive. I mean, education is the great social leveler, and everyone knows this. Children, based on the Iceland study, are not spreaders of the disease. If they do get it, they're a low incident situation. The chance they're going to infect their grandparent is low. A grandparent who is over 70 with no underlying disease does not have the same risk as a 6-year-old with multiple comorbidities who is going unnight. So we can't tar everyone with the same brush over 60, but still, as Lord Monkton said, segmenting the population under 60, especially otherwise healthy, and allowing them to lead life as usual, and even let's start talking about travel and opening borders, I think it's reasonable to go there.
All right, we need to take a short break. There's more of the Zoomer when we return.
If we had large-scale testing, then we could truly understand what the mortality rate is.
Welcome back. Without a vaccine in sight, and as governments begin to lift COVID restrictions, many fear a second wave, potentially as fierce as the first. What factors will determine what's coming, and is there any way to control it? Dr. Gorfinkel.
Well, I think the big piece we're not talking about here is the need for better testing. If we had large-scale testing, then we could truly understand what the mortality rate is. We've seen mortality rates as low as 1% and as high as 6%. But the mortality rate may be actually much lower than that if we're to believe, for example, the Icelandic data saying that 50% of people can be asymptomatic and simply carriers. Another large piece is we actually do not know just how much asymptomatic shedding is going on. So there's that type of testing for the virus, and of course the race for the golden goose, which is trying to find that serological testing. The testing for the antibody that shows somebody is actually safe to go back to work. Somebody is safe not only for themselves, but they're not going to infect somebody else. So there are huge pieces of this puzzle that are unfortunately missing. But the one thing the lockdowns do provide us is the time to get closer to those solutions.
Lord Monkton, are you having the same challenges with access to testing and making sure that they're deployed at the right locations, particularly long-term care homes that we've
The
seen here in
government
Canada?
has sadly neglected testing in the care homes. It is now about to put that right. And it was very slow to get any form of testing off the ground, and has recently called in the army at my suggestion, among others, because the Royal Logistics Corps knows how to get stuff moving and get stuff done. And they've done an absolutely superb job. But talking of the figures that Dr. Iris has just been talking about, we do now have some very good figures from the United Kingdom. First, from a study of 275 patients done in ICUs by our Office for National Statistics, and more recently a much larger survey of 1,600 patients in 166 hospitals. So we now know and can say to a very high degree of statistical confidence that the point that my noble friend Lord Black has been making, which is that the under 60s are essentially not really at risk, is now known to be the case. And the only question, therefore, is how to make sure that the doddery old fools like me, who are over 60, look after themselves.
Isn't part of the fear, Dr. Zach, our hospitals being overwhelmed by COVID-19? And, you know, if you open the world and all of a sudden you've got a number of people entering into ER, overwhelming our hospitals, that puts an enormous amount of strain on our system. Do we have the capacity to handle this? And the other thing I would ask is we still don't really know a lot about immunity when it comes to this virus. There have been reports of people testing positive for COVID-19 twice. I don't know if they're necessarily accurate, but those reports are out there.
In terms of capacity, that's one of the concerns. But the people I worry about, like I said, older, younger, and then the people who aren't coming to the hospital because they're scared. So people keeping their loved one home with a stroke. I know someone like that. And the people who aren't getting their treatment, for example, chemotherapy being held. But having said that, there are good reasons for that, because you're right, the capacity, once we open everything up and the whole hospital is working as it usually does, if we no longer have ICU beds, then we end up having to make those awful choices of who gets a ventilator. You know, if two people, how do you decide who is worthy of getting a ventilator? I don't think it's simply a matter of age or comorbidities or whatnot. That's an awful choice that we're trying not to make. Let me just say one other thing, and you were mentioning immunity, and Dr. Rao would know better than me, but from what I've heard, we still don't know 100%, although we believe there's probably immunity like there is to most diseases. But for testing, what I've seen so far is up to a 30% rate of false negative testing. And so that's the problem. Even if we test everyone, many people are asymptomatic. If we have a significant number of false negative tests, then there are a lot of people walking around with the disease, with the infection, who don't know they have it. And so they don't know to self-isolate.
Dr. Rao, can I get you to comment on that?
Zach, you're raising some good points. I mean, the whole persistent positivity thing, it's probably due to the molecular test that we use called PCR, where we're finding the genetic material of the virus, but not necessarily live virus. So the reinfection theory is probably being debunked. As far as immunity, whether it's true, durable, long-lasting immunity or short-term immunity, we don't know yet. It's probably, at least to some degree, long-term immunity for a part of the population, and then some of it is not fully immune, and there may be a drift in the strain, and we might see waves of this again to a lesser degree, the same way we do with influenza. But one thing that is clear is what Dr. Zach raised, that we can't find every single case, and every test has its limitations. This disease is widespread in the community, and much more widespread than appreciated initially, partly due to the dishonesty of the Chinese not telling us the truth, and partly due to the fact that we're finding out more. If you can't stop a virus that is widespread, you have to live with it, let it infect those who are not at risk, and build up herd immunity. I think if you were to take every nursing home and walk kids through it and walk communities through it, that would be a bad idea. No one's saying to do that. No one's saying we should open up the hospital where I work. And also, we can't test everyone. We already have a shortage of kits and reagents. I run the lab here. We can't test everyone. We have to be selective. We have to think of it like political polling, where you do sentinel testing in certain environments and you find out the rates of infection, but you don't test everybody. You determine a government's popularity through sampling in certain communities to know what the government's popularity is overall. You don't phone everybody in the community before the election. Same idea with testing. You can test sample groups and find out what's going on without testing every single person.
All right, we'll be right back after this short break.
It does, however, reduce the risk of acquiring the infection and reduce the severity if you get it.
These are simply not proven treatments, nor are they proven preventions.
Welcome back. People keep saying it. Everything has changed. So what will be COVID's lasting legacies and what are some lessons learned? Lord Black, in a recent column editorial you write, if COVID-19 has taught us one thing, it's that Canada needs to be more self-sufficient. On what exactly? Maybe you could elaborate on that.
In the case of Canada, I was objecting to the fact that we lack a great many things, but that included a serious aviation industry, ownership of our own automobile industry, and a lot of other things that G7 countries shouldn't suffer from. So it ramified what I said far beyond what we're talking about here. In fact, as far as I can see, the Canadian medical profession and the suppliers to it behaved quite competently, and our numbers are relatively good. But I do agree with the suggestion that's been made that if we just opened up everything with the provisions especially made about elderly people and especially homes for elderly people, we wouldn't do worse than Sweden. And Sweden is about almost 3 times as high a fatality rate per capita as Canada, and somewhat higher than the US, but below, I believe, Britain, and certainly below France, Italy, and Spain. And they never had a shutdown.
Dr. Gorfinkel, as we move forward, what are some lessons that we can learn from all of this, particularly as they relate to our long-term care facilities, our congregate settings for older adults?
I get concerned because, especially when strong political statements are made, there's a lack of emotional agility, and that worries me. I think our public health units could definitely do with much better funding. It came as a great disappointment to see that our emergency stockpile was nowhere to be found when our healthcare workers so desperately needed it. If there were a way to reduce the number of infections, it would have been to provide practically unlimited personal protective equipment at the front lines when they were most needed.
Personal protective equipment for sure, and that's something that I know the Ontario Premier has received a lot of criticism for, but also been critical of in terms of access to testing of our public health officials. Dr. Zach, what do you think are some lessons learned here?
I think we've done, whoever, the media, the government has done a great job educating people about the seriousness with which this needs to be taken. But there has to be some nuance, and we have to have the ability to have a proper conversation and debate without just taking two opposite sides, because we're constantly learning. Like Dr. Gorfinkel was saying, we have to be able to learn, and we are. And one of the things that you brought up earlier was the idea of ventilators. Well, the whole management has changed. It went from intubate people and ventilate them very, very early to delay that. You know, people don't necessarily need to be intubated right away, so maybe we don't need as many ventilators. When people do, they definitely do. But we're learning all the time. It's still very early in the course of our knowledge about this disease.
Dr. Rao, can I get you to comment on that?
I think, though, as we get this information, we have to adapt to it. We don't just carry on come hell or high water. We have to start adapting to emerging information. It's true, we're still learning, but it's becoming incredibly clear, as Lord Buckton said, that the mortality of this disease is not that high. In fact, Lord Black is using numbers that are very much on the conservative side. The real risk for someone under 60 of dying from this disease is 1 in 150,000. And it's probably even lower if you don't even have an underlying medical disease. So this is really the common cold for people under 60, and it's incredibly deadly when it enters a nursing home, much different from the standard seasonal flu. And so we have a different approach that we can cater to each environment. But what I don't see is an adaptation to emerging information. The other thing I see is a moving goalpost, which isn't fair for society. A lot of people want to get on with their lives to some degree, open their cottages, be outdoors, play outdoor sports, and get their kids back to school.
Lord Moncton, final word before I throw to break.
What we do know, for instance, is that if you take 25 micrograms of vitamin D3 in gel tablet form once a day, your risk of A, getting, and B, suffering from COVID-19 is very greatly reduced, as it is for all respiratory diseases, including colds and flu. So there is an enormous amount of peer-reviewed, well-established scientific evidence, not only about respiratory diseases in general, but a huge meta-analysis done in one of the big British medical journals just 2 years ago. So vitamin D is an absolute no-brainer. There are no side effects. You can buy it over the counter. Just do it. Don't even have to ask your doctor, though my advice is always ask your doctor first. But these are things that if you do those, you can minimize the risk. And I think we can see the back of this by Christmas if we play this right.
Actually, Dr. Gorfinkel, let me get your thoughts here.
With all due respect, there is no known prevention, there is no known treatment, and there is certainly no known cure. So let's not be reductionist. If we look at the history of various vitamins, whether it's vitamin C or vitamin D3, it's generally a history fraught with error and fraught with misstatements. And I have to buck against what I'm hearing because these are simply not proven treatments, nor are they proven preventions.
Martineau et al., 2017, 10,500 patients studied in a meta-analysis of clinical trials of the efficacy of vitamin D against respiratory infections. There have been numerous studies ever since. This is not a cure, nor did I say it was. It does, however, reduce the risk of acquiring the infection and reduce the severity if you get it. That is well established in the literature, and to say that it isn't is to misrepresent the science.
So there may be a following for various vitamins. But I have to tell you, and I think my physician colleagues will readily agree, that in fact, vitamin D3 is neither proven to prevent it nor to treat it. We do not have anything that is known to treat it as yet that is ready for prime time. The CDC has yet to embrace this. Health Canada has yet to embrace this. I respect your opinion.
Public Health England has embraced it, I'm glad to say.
There is no agreement on any proven therapy at this point. We need the data.
Dr. Zach, can I get you to weigh in here?
What we are using right now, for a little while we were trying hydroxychloroquine. Then based on the studies, it wasn't found that it was more effective than it was harmful. So we're not using it. In general, we're using, and also we're using Tamiflu, which is an antiviral, and not anymore. Now they're talking about remdesivir, but that is not part of the standard treatment yet. So things are constantly evolving.
Dr. Rao, very quickly.
There is a trial underway with infusions of vitamin D for critically ill patients, not proven to work yet, but for prevention of respiratory illnesses, I don't think it's harmful to use vitamin D, but I can't endorse it as proven yet, but I think it's provocative, and I don't think we should throw it away as an idea.
All right, we need to take a short break. When we come back, final thoughts from our panelists. Welcome back. It's that time in the show for final thoughts from our panelists. We'll start with Dr. Zach.
Two things. One is for us to be able to have sensible conversations and debates and base it on the information and the knowledge that we have, and to continue to be able to evolve our treatment and our public policy based on the knowledge that we have. And the other is we have to balance the knowledge that this virus can be deadly for older adults and people with significant comorbidities, with the idea that people need to have quality of life and that we can't keep our society on hold forever, and that there's a fair bit of damage being done by keeping people isolated, socially, emotionally, psychologically. And unfortunately, we're gonna end up dealing with that when we do open things up again.
Lord Black.
I think that in general, given the proportions of the fear that were, for the most part, rightly generated, all our countries have done relatively well, some better than others, and some have been luckier than others. But in fact, we clearly are gaining the upper hand on this, and we should act accordingly. And it is a considerable risk to a small number of people and a minimal risk to a large number of people. And our strategy in each country should reflect that fact. That doesn't mean a 100% reopening of everything. We just act prudently. And there has been a lot of political posturing, and much of it has been generated by the fact that it's an election year in the United States.
Lord Monkton.
I would like to say that we should have hope at this stage, because we are a clever species. We are better at adapting to things than to mitigating them. And both our immune systems, which learn very fast how to deal with new threats of this kind, and our increasingly clever medical profession, many of whom you've heard here today, and they're very learned people and they know what they're talking about. We will, between us, get on top of this, and relatively rapidly so. To governments, I say this: you were behind the curve, not entirely through your own fault, at the outset. You don't need to stay behind the curve now. It is safe to unlock gradually but steadily the population below 60. Let them go back to work, let them go back to school, monitor the results, adjust and adapt as necessary. But it is time to set us free.
Dr. Rao.
I worry about snitch lines, about people spying on their neighbors, being fearful of their neighbors, of people's fear of contagion. You know, the germaphobe in us has been unleashed, and that's what I fear the most as a consequence. And how are we going to undo the messaging of this, the strategies to contain this disease, which is uncontainable, and revert back to having society being more warm and caring, interactive, integrative, and also active, you know, on an outdoor level, so that we can combat other problems like obesity and heart disease and diabetes.
Okay, and Dr. Gorfinkel.
My hope is that as a society, we value clarity and thinking. And by clarity, I mean admitting when we were wrong. And I'm glad we had that clip, so that it creates a space for intellectual and emotional agility. And I'm talking about our health leaders. And I also feel that that piece of valuing pandemic preparedness is so important here. We need to stockpile again. We need to get back to that, and we need to value that so that we are ready when it comes. The self-sufficient piece is also important. And the final thing is for health consumers not to give in to reductionist solutions. They're tempting, they're simplistic, but unfortunately we need to look hard at data to understand what therapeutic avenues are in fact safe and effective for us. So I'm grateful to Health Canada, I'm grateful to the CDC to take a really hard look and say, what should we be valuing? Desperation does not mean take whatever is available. Desperation, I understand that, but there's a space for just stand there and do nothing, understand, take the clarity in, and understand science rather than hope.
That's all the time we have. Thank you to my panelists for your expertise and for being here, and to our loyal audience watching from home. We'll see you soon.